This from the previous lecture? All right, so this lecture, you should just kind of hang out and listen to this lecture. All right, anybody read blood gases before? Have any knowledge of blood gases? Taught about it in any other classes? Just the Allen. Okay, that's about the extent of it. So I'm gonna tell you now that this is gonna be something you're gonna latch onto it a little bit during this lecture, and then by the end of the lecture, be like, I think I got it. And you're gonna forget about it, and you're gonna go to study it, and you're gonna have no recollection about what we spoke about, which is totally normal. But you're gonna be able to read blood gases in your head within like 2 seconds. While everybody else is just like putting it into their calculators or whatever app they're using on their iPhone, you're gonna be able to do it in literally 2 seconds. But it's gonna take your brain a little getting used to how to read them. But once you have it, you'll never forget. It's like riding a bike, you'll always be able to do it. So I'll tell you what you need to know. Just kind of try to absorb the information as we go. You guys took chemistry, right? Chemistry is awful, right? This is chemistry.
Oh.
But I'm gonna make it easy. It's gonna be easy, but chemistry, you can't memorize chemistry really, the equations. So it's kind of like that. But when you get it, you've got it. Everybody get what I'm trying to say? So just relax, listen to what I'm saying. If I'm going too fast, you'll let me know. But really all this is it's a pretty invasive procedure. It's an arterial stick. Whether we're using it in the radial, whether we're using it in the brachial, whether we're using it in the femoral. We try not to go to femoral because it's a lot of times contaminated. So it's an arterial stick to get measurements to see if we have primary ventilatory abnormalities or primary metabolic abnormalities. So 99% of the gases you're going to be able to figure out in your head in a couple of seconds. There are going to be some that are going to be combined gases, and those get a little messy, all right, where we have combined respiratory and metabolic alkalosis or acidosis. That's a very small part of this, and I wouldn't bog your brain down with that right now. The whole premise is to be able to how to read respiratory abnormalities, metabolic abnormalities, and compensation. And this is what kind of throws students off, is the compensation part. Everybody is latched on and is really good when it comes to either determining metabolic or respiratory. Then when it comes to compensation, the wheels fall off. So kind of just bear with me a little bit. So what we're doing is we're trying to, like I said, we're trying to discriminate whether we have a ventilation abnormality, pulmonary, or a metabolic abnormality. And the metabolic abnormality that we're typically talking about is controlled by the kidney, right? So bicarbonate is typically controlled by the kidney, right? So that's how we're going to start to determine what we're primarily seeing. So if somebody comes in with diabetic ketoacidosis, you're going to do a blood gas. That blood gas is going to be totally out of whack. Without knowing what the patient came in for, and you only had a blood gas in front of your face, you could determine that the patient has a metabolic acidosis and they're trying to compensate with the respiratory system. You'll be able to know that. You didn't even see the patient. You don't even know what they have. Here's the blood gas reader. You're going to be able to determine that. So what we use a pre-filled syringe. If anybody's worked in the ER or the ICU or wherever, we have these pre-filled syringes. They're heparinized. These heparinized syringes are made for arterial sticks. So you guys, you spoke about the Allen test, right? What's the primary feeder artery of the hand? Radial ulna. It's the ulna, right? So we always do the Allen test first. Are we going to want to poke somebody's radial artery if their ulna is incompetent? Probably not. Go to the other hand. Okay, so these pre-filled heparinized syringes are available. They're all over the place, and you can get this reading back in seconds. All right, so the units have the machine to read it. The ER has a machine to read it. You'll do the blood gas, and you'll have this back in 15 seconds. You'll have the results back. The heparin that's inside of that syringe, squirt it out. I just kind of squirted on the patient's bed sheet. All right, it's like a cc. It's like a cc of heparin, but that heparin can whack out the CO2 and the bicarb. You don't need it. You don't need it. By you squirting it out, that syringe and the needle is already primed with heparin. You don't need all that heparin in there. So it can alter your CO2 and your bicarb levels. So get rid of it, but use that needle. Now you guys know that they teach you that when you do this arterial stick, It's all done sterilely, but when you do this arterial stick, you don't have to draw back on the plunger to get blood out, right? Did they tell you that? It will automatically fill up immediately. Once you're in the artery is pressurized. Once you're in the artery, that plunger, it's going to fill up that syringe, it's going to fill up with blood. Take out the needle and maintain a lot of pressure on the radial artery, right? Because it's going to bleed. It's going to bleed. So what we're looking for is the pH, the partial pressure CO2, the partial pressure oxygen, the bicarb. There's something called base excess that we're going to talk about. Now, base excess is a useful tool. It's primarily used for metabolic abnormalities. Write that down. Put a star next to it. Primarily used for metabolic abnormalities. Almost all, but you can never say all, right? Almost all. This will be abnormal in a metabolic abnormality. And what this is saying is, it's actually telling you how many hydrogen ions do you have to take away, or how many hydrogen ions do you have to give back to the patient to bring them down to a normal pH of 7.35. That's all it said. So if you have a patient that has a base excess of +3, and base excess it goes on a grid. The normal levels are -2 to 2. So -2, -1, 0, 1, and 2. That's the normal, right? You don't even have to write that down. I have that somewhere. So if I tell you that somebody has a base excess of +3, they have a what? And if they have a -3, you have to take away 3 hydrogen ions, that -3. Take away 3 hydrogen ions to bring them back up to a pH of 7.35. So if you have to take away 3 hydrogen ions, hydrogen is acid. If you have to take away 3 hydrogen ions, that means that they are in an acidotic state, right? On the flip side of that, if it's saying a base excess of +10, that means you have to add 10 hydrogen ions to them because they're alkalotic. Add 10 hydrogen ions to them to bring down their pH to 7.35. Does that make sense? This is primarily used for metabolic problems. Remember that. So in respiratory states, this is typically normal. In metabolic abnormalities, this tends to get whacked out. Okay, so your patient that comes in with diabetic ketoacidosis. The only reason why I keep saying DKA is because people know it and they're very, very acidotic, like they'll die. Okay, it's an emergency. So they may have a base excess of -15. You have to take away 15 hydrogen ions to get that patient back to a base of 7.35. Does that make sense? That's a metabolic problem. It's not a respiratory problem. So when we're talking about the acid-base relationship, we're talking about 2 functions that we're focusing on right now: the respiratory system and the renal system. Okay. So we have 2 buffers, carbonic acid and base bicarbonate. These are linked to the respiratory system. So in this, you have to look at this slide and say, what the hell's going on here? What this is saying is that you have base, you have bicarb, which is a buffer. We know that bicarb is a buffer, right? So it tries to equalize things. It'll make you more alkalotic. And without it, you get acidotic. Or the CO2. This is important. Circle that CO2 at the bottom. And write, this is an acid. You have to think of CO2, not serum CO2. Did you guys do lab medicine? So lab medicine, in your basic metabolic panel, it's got a CO2 level. That's not this. That's CO2 in a serum, in a basic metabolic panel. That's reflective of bicarb. But in a blood gas, that CO2, for all intents and purposes, that is an acid. So the more CO2 you have in your body, what do you think happens? Alkalotic or acidotic? Acidotic. The more bicarb in your body, alkalotic or acidotic? You drop your CO2. What happens?
Alcohol.
You get alkalotic. You get dizzy, you pass out. Anybody here ever hyperventilate and feel dizzy and feel like they were going to pass out? Did you ever see them? They make you breathe into a brown paper bag. Why? You're rebreathing your CO2 in. That hyperventilation keeps dumping off the acid. You're dropping your acid. You're getting alkalotic. You get dizzy and you pass out. So if you keep breathing into that brown pepper bag, what are you breathing in? CO2. You maintain your CO2 level. Therefore, you don't pass out. And you maintain that pH. The metabolic component, we're talking about the kidney. So there's sodium bicarbonate. So there is a point at which bicarb is secreted and reabsorbed by the body from the kidneys. It exchanges for hydrogen. So your kidneys suck up bicarb and put it into your body and take hydrogen and excrete it. So if you go into kidney failure, we call it acute kidney injury now. We used to call it kidney failure. If you go into kidney failure, are your kidneys going to work properly? So are you going to be able to produce bicarb? Are you going to be able to exchange the hydrogen for bicarb? What is hydrogen? It's an acid. What is bicarb? So if you can't buffer all that acid that you're holding on to, what happens when you go into kidney failure? Is it metabolic or is it respiratory? See how easy this is? It's very simple, right? You're halfway to reading blood gases. All this is saying is that we have a very, very narrow therapeutic window for which our body can tolerate acid-based disorders. We do not tolerate it very well at all. At all. And our body does a very, very good job at always protecting itself. That's the compensation part. We get totally whacked out, delusional, encephalopathic. We could die if our bodies fall out of a very narrow therapeutic range. Our range that we like to be at for pH is 7.35 to 7.45. There is not a lot of wiggle room there. You drop your pH from 7.35 to 7.0, you could die. It's not a lot. Right? That's not a lot. It's 0.35. It's nothing. You go from 7.0 to 6.8, good chance you're going to die. It's not tolerated very well at all. So we start people on bicarb at 7.1. We don't mess around with it, right? Because they don't tolerate it well. Has anybody ever been part of a code? Have you ever seen somebody coded? You seen somebody coded?
But EMS not.
That's fine. EMS still codes people, right? Mm-hmm. So they're coding somebody, they're doing compressions, patients unresponsive, maybe they're intubated, they're throwing drugs at them left and right, epi, atropine, this, that, and the other thing. Did you ever hear him say give him an amp of bicarb?
Yeah.
Why?
Very down.
What happens?
Metabolic.
You get a metabolic acidosis. Why? Kidneys aren't functioning. And you're also beating on their chest. What are you doing to them? You're causing what? Trauma causes acidosis. Do we know what their bicarb level is? No. Are we saying everybody stop doing what you're doing? Let's get the bicarb and let's see if we should give it amp. No, we don't. We have to assume. But that's the whole premise behind it. Does it increase your heart rate? It doesn't do anything to your heart. It's only to control hemostasis. You have to know this slide. You have to know this. So I'll get a call from a nurse and they'll rattle off a blood gas in 2 seconds. They'll rattle off the blood gas to me. But I don't say, what's the normal value? Right. So you have to know this slide. All right. So pH is 7.35 to 7.45. CO2 is 35 to 45. So the way I think of things in tandem. I'm a very tandem person. Right. So I have a cadence to everything that I think about or do. Everything is in a cadence. So pH 7.35 to 7.45, CO2 35 to 45. So if you think about it like that, it kind of helps you, right? These numbers match these numbers. Okay. PCO2 80 to 100. What's more specific, PCO2 or a pulse oximeter on your finger? PCO2. Much more specific, much more sensitive. 80 to 100. Anything below 80 is hypoxic or respiratory failure. Bicarb 22 to 26. Base excess, -2 to +2. Now, your oxygen saturation for a normal person, not COPD or emphysema, cystic fibrosis, interstitial lung disease, any of those things, congestive heart failure. You want it greater than 95. All of us here should be greater than 95. All right. If not, you're hypoxic. Okay. So if you're a COPDer, I let some COPDers that are stage 4 and stage COPD, I want them greater than 88. I'm happy if I can keep them above 88. But the majority, if you're just a regular COPD or emphysema patient, well controlled, you're not end stage, I want you greater than 92. So 90 to 92. So we have that leeway, 90 to 92. So it really depends. Would I let you guys go down to 90 to 92? No. Would I let you go down to 88? No, that's respiratory failure. So no. But that O2 on your finger is really not sensitive. You know what I've learned about those? I've learned not to trust them. That's really what I've learned to do. Okay, because you could have somebody that's satting at 99% on room air with that little meter on your finger, the pulse oximeter, and they're in respiratory failure. How is that possible? But not that it's not accurate. Maybe the oxygen is 99%.
It's only finger that they're maybe in a different area.
It doesn't tell you that bicarb, right? It doesn't tell you that CO2. Your oxygen, if you're a COPDer, your oxygen maybe 94%. But your CO2 hold could be 100. You're in hypercapnic respiratory failure. So it doesn't tell you the whole story. So you have to be very careful with it. So very important to realize when you have somebody that has an elevated CO2, I told you that CO2 is an acid. What's going to happen with the pH every time acid goes up? pH goes down. Every time acid goes down, they're always opposite, right? CO2 and pH are always opposite. They should always be opposite. Always. Okay, they're always inverse. Because it doesn't make sense any other way. If you have an acid, too much acid, it has to drop your pH. Too much acid cannot raise your pH. Now, on the flip side of that, your bicarb should follow with your pH, right? That's the buffer. You add more buffer to the patient, you increase the bicarb, you increase the pH. You drop the bicarb, you drop the pH. Does that make sense? So pH and bicarb should always flow together, correct? So CO2 and pH should always be opposite. Bicarb and pH, they should always flow together. Remember that, because that's going to help you when it comes to compensation. Miss what I said? Anybody miss what I just said? You good? Okay. So what do you think is the most important part of a blood gas? pH, bicarb, oxygen, base excess, CO2. Well, what's the most important? If I gave you one thing to look at, what's the first thing you want to know? pH, CO2, bicarb, oxygen. Nobody dies of too high of CO2. Do you die of low oxygen? Very quickly. Oxygen is the most important thing. Hypoxia kills. Respiratory arrest kills. Okay, we can always correct the CO2 at some point. But with oxygen, if you don't supply the cell with oxygen, what happens to it? It dies. What happens when you don't supply muscle with oxygen? It dies. What's an MI? It's an infarction. You strangulated the heart muscle of oxygen. And what did it do? It died. All right, or it got insulted. So without that, you have to correct that first. It's the first thing you want to look at, always. Then the second thing you want to look at is your pH. You want to know where is your patient? What is your patient doing? At what point do we have the patient? Are they normal pH? And normal pH does not mean a normal blood gas, by the way. You have to look at everything as a whole. It's not just one thing. You have to look at it. You have to look at it with a big lens, not a very small lens. So pH, is it low? We're dealing with somebody that's acidotic. Now we got to figure out what kind of acidosis and are we compensating it? If it's high, well, obviously we're dealing with an alkalosis. What kind? Metabolic, respiratory, and are we compensating? Normal pH, that's okay. Are we hypoxic? Are we corrected? So, you know, there's things that you have to look at. But always thinking of CO2 as an acid, which means if CO2 goes up, pH goes down. That's for acidosis. Now, you can memorize these things if you want. I don't choose to memorize really anything. There's a couple things you have to memorize, right? You have to memorize the numbers I gave you. You have to memorize Ranson's criteria. You have to memorize certain things. You have to memorize milestones for pediatrics. But 90% of things you can rationalize. I don't store up my limited memory with junk like this. Okay, so you could just theorize it. What does COPD do? They have a hard time breathing out, not a hard time breathing in, right? They clamp down breathing out. That's why they get the big barrel chests. So what happens? They hold on to. So what's going to happen to CO2? Going to rise. Right now, do they walk around in acidosis all the time? No, because our body compensates for it. Drug overdose. You take heroin. You take heroin, you pass out, you vomit, you asphyxiate. You go into respiratory arrest. What happens to the CO2? Goes high. They hold on to all the CO2. Any airway obstruction, you hold on to. You can't get anything out. Metabolic. So, metabolic acidosis, pH is low with the low bicarb. Again, they float together, right? Bicarb goes down, the pH goes down. What happens if pH goes down and bicarb goes up?
Compensation.
That's compensation. That's compensation. We'll talk about that. So anion gaps. Did you guys learn anion gaps yet?
No.
You did? What did they tell you about it? So 11, 12, 13, depends on the lab, but what did they tell you? Why to use it? So anion gaps kind of tell you where to think about your acidosis is coming from. And this only works for metabolic issues. So we try to think of possibilities or differentials of why we have abnormal anion gaps or somebody that's acidotic. So you could have a normal gap acidosis, or you can have an abnormal high anion gap acidosis. So to calculate the gap, you do the chloride plus the bicarb minus the sodium, and that's your gap. So you get a gap of 26. Normal is anywhere from 11 to 13, depending on the lab. Some labs will just give it to you right away. Some you'll have to calculate. Chloride plus bicarb minus sodium. So this anion gap, if it's elevated, kind of gives you a differential of what could be causing that. So if you have a normal gap, let's say your anion gap is 5. All right, let's call it 5. That's a normal gap, but they're acidotic. So think of increased loss of bicarb in those patients. Where if you have an elevated gap, think about organic acid increasing. And I'll tell you what that means. So normal gap, losing bicarb, diarrhea, isotonic saline, keep infusing them. Acetazolamide, which is Diamox, which we commonly use in the unit to get people off events. We commonly correct holding on to or retaining CO2. We also use it for altitude sickness. You know, you want to go climb Machu Picchu. You know, the altitude's very, very high. You're going to get altitude sickness. Acetazolamide, which is also known as Diamox, works very well for that, but it can also cause normal gap acidosis. Abnormal gaps, elevated gaps. Think of the pneumonic mud piles. Did they tell you this? Who taught this to you?
Who's physio?
Really?
Media name.
Sullivan? Oh, he's a good guy.
That's it too.
So think about mud piles. This gives you a differential of what this could possibly be. Methanol, uremia, isoniazide, iron, lactic acidosis, salicylates, right? Drug overdose. So salicylate's a what? What's a salicylate? Aspirin. Ethylene glycol, very common. All right, people will drink ethylene glycol. You know what that is, right?
Looks for a fridge.
Antifreeze.
Mhm.
Antifreeze. So antifreeze, people will drink this a lot of times, one for suicide, for attempted suicide. But two, there are some gangs where I train that would make you drink ethylene glycol. And if you survive the ethylene glycol, you're in the gang. All right, so ethylene glycol poisoning. And if you've ever, I'm not telling you to go out, please don't go out and try. But if you've ever tasted it, if you notice, if you leave a bowl out, cats will be drawn to it, animals will be drawn to it. It's very, very sweet. It's very, very sweet. But it puts you into renal failure like immediately. Pushes you to get acidotic very, very quickly. Respiratory alkalosis. So your pH has got to be greater than 7.45 to have an alkalosis. And if it's respiratory, that means it's the CO2, right? Not the bicarb. So if you're in an alkalotic state, where does that CO2 have to be? High or low? Got to be low. You have to be blowing off or dumping off all your CO2, which is your acid, and it raises your pH. Everybody got that? If you got it, you're reading blood gases. If you don't, tell me now, because I don't want to keep moving until you know. Everybody's good?
Mhm.
Yeah? Okay. Again, you could do this causes of alkalosis, but you could theorize it. So if you hyperventilate, you're blowing off all your CO2, right? You're going to raise your pH. Anybody panics, pregnancy, acute anemia, salicylate overdose. They're usually tachycardic, tachypnic. Red as a beet, mad as a hatter. Have you heard of that?
No.
Dry as a bone. Yeah. Metabolic alkalosis. So metabolic, we're dealing with bicarb. Alkalosis, pH has to be high, bicarb has to be high. Easy. So, loss from the stomach or kidney, excessive alkali intake, and hypokalemia. Typically, hyperkalemia will make you acidotic. Hypokalemia typically will make you alkalotic. So remember I told you how to analyze the blood gas. One, always, what's the oxygen? 80 to 100. If it's not 80, correct it. Can you get an oxygen level that's over 100? You can. You actually overcorrected them. So maybe they're vented and you have them on a certain amount of oxygen. You could turn down their oxygen. Maybe they're on 50% O2. Maybe you have to back it down to 30% or whatever it may be. pH, high, low, and normal. And if it's high, are they trying to compensate it? If it's low, are they trying to compensate it? Is it respiratory or metabolic? And if it's normal, did they compensate? Or are they just fine? So when we can always look at O2 and pH independently. These two guys, you have to look together. CO2 and bicarb, you want to look at them together. They should not be, if you have an abnormal pH should not have a normal CO2 or a normal bicarb. So that pH will determine what happens to your CO2, your bicarb. And this is where you get compensation from. So real quick, if you have an abnormal pH, let's say your pH is very, very low. Okay. And you have a high CO2. What is that? Respiratory acidosis. Now, I told you that pH and CO2 should always be opposite, right? And I told you that the bicarb and the pH should stay together. But what happens if you have the very, very low pH the very, very high CO2. And what happens when the bicarb is also very high? That's your body trying to compensate. So really what I just said in a nutshell is, if you have an abnormal pH, and if the CO2 and the bicarb are trending up or down together, that means there's compensation somewhere. Now you just have to find out what the primary problem is. Is it metabolic or respiratory? If they're not trending together and you have an abnormal pH and one of them is abnormal, it's easy. It's not compensated. Does that make sense? Abnormal pH and both the P and the CO2 and the bicarb are either high or low and they're together, there's compensation there. Doesn't mean it's fully compensated. They're trying to correct. Now just figure out what the primary source is. We spoke about all this. So, are you guys good? Question? You good? You all right? So again, we look at our oxygen. Okay, then we look at the pH. 7.35 below that is acidotic, above 7.45 is alkalotic. Everybody's good with that? Then we have to look at the bicarb and the CO2 together. Respiratory irregularities will have an abnormal CO2 with a normal bicarb. Does that make sense?
Oh.
Good?
See it.
Good with that?
Mhm.
Abnormal CO2, normal bicarb is a respiratory problem. Where did my slide go? Metabolically, if you have a metabolic issue, you have an abnormal CO2, which is lung, with an abnormal bicarb, which is kidney. That's metabolic. We're all good with that, right? So what I'm trying to say is if you have a pH that's 7.1 and a bicarb that's 10 and a CO2 that's 40, what is that? Low pH, normal CO2, low bicarb. Metabolic acidosis. High pH, low CO2, normal bicarb. Respiratory alkalosis. Everybody see how they're getting that if you didn't get it? Don't be shy. You good? Because if you don't get it, this is really going to mess you up if we move any further. So is everybody solid with that? Okay, who's talking? Okay. So you have, let's say, high pH, normal CO2. So what's high pH? So it's alkalotic, right? Normal CO2, high bicarb. What is the equation? You have an alkalosis, you said. Now you have a normal CO2, that's the lung. You have an abnormally high bicarb, that's the kidney. So what do you have? Metabolic alkalosis. Or the bicarb is abnormal. Right? So look at it that way. So you have an elevated pH, but your bicarb is metabolic. CO2 is respiratory. So if your CO2 is low, and I'm sorry, if your pH is low, what is that? That's acidosis. Normal CO2, low bicarb. What is your equation? Bicarb is low. Nope. Metabolic. Probably better if I draw it out for you. You guys have markers over here? You have marker? Give me one that's not gonna be frozen. Outside. Yeah, it's off, that's what. All right, so pH. High. CO2. Low. Bicarb. High. So this is, what is this? Alkalosis. This is what? Respiratory or metabolic? What is this? Bicarb, metabolic or respiratory? You have a metabolic amylosis. This should be normal, sorry. Normal. Okay, you have a metabolic alkalosis. Now, if you have this. If you have this, CO2, your CO2 is low and your bicarb is normal. Respiratory alkalosis. Got that?
Yeah, we're overcompensating.
You won't typically overcompensate. The only thing that you will overdo is oxygen. You'll be lucky if you could fully compensate. You can overcompensate if you have somebody vented and you're controlling the vent. Okay, so your metabolic things for acute abnormalities, metabolically, you can't compensate. All right, so you can't have a metabolic compensation for something that's so acute. But for chronic, you can. So think about your COPDers. COPDers, what do they do to their CO2? They trap CO2, right? They hold CO2, they retain. Do they walk around with a respiratory acidosis all the time? If their kidneys are functioning normally, they'll have a pH that's normal with a high CO2 and a high bicarb. Does that make sense? So that's an example of me saying, well, if the pH is normal, then they must have a normal blood gas, and that's not true. They have a compensated respiratory acidosis.
That's the case with the pH is going. How do we know what the risk happened? So can you just give us, pH normal?
So- That's the greatest question, because that's how you can determine if you have compensation, right? So if you have somebody, let's say you're a 70-year-old COPD, right? And your CO2, your pH, let's call it 7.35. And your CO2 is 70. Your bicarb, 303. Let's make your bicarb 45. So this is high, this is high, this is normal. Right, so what do you see here? This both go high, right? So your question is, how can you tell what it is? Well, if
Like, you know, the case, like.
Sure, absolutely. So there's an inverse direct relationship between bicarb and CO2. All right, so between pH and CO2, so which means that every amount that your pH goes up or down, the CO2 will do opposite, and that's how you can tell. But the other thing is with this, if you look at this and say, well, what if my base excess BE was, let's call it -1. What is it now? So what's the normal base excess?
Oh, so that's normal.
So it's normal. Where do we see abnormalities with the base excess? Only with. That's a respiratory issue. So you don't always need the BE. There are going to be some that you must have the BE. You don't always need it. If you want to figure out the math with the inverse relationships between CO2 and pH, you don't need the BE. But you can, if the pH is normal, you can always look at the base excess. If the pH is normal, there is a math equation, which I am not going to hold you responsible for because you don't really need it. 0.5% of the time you're going to need it. All right, and Phil would love to teach it to you. He loves this. Phil loves this. I will tell you, you will be back to me saying, can you explain blood gases again? Because Phil also did it. Now we're almost done. So, but you can do it just by looking at that. It's not metabolic. That's not because you have a normal base excess. What if your base excess was abnormal? In the far majority, it's gonna be considered a metabolic issue. So the last step in all of blood, oh, here's your pen. The last step in all the blood gases is determine if there's compensation. You can determine if there's compensation if the CO2 and the bicarb float up or down together. That's it. That's compensation. All right, if they're not, there's no compensation. So if you just have pH up, CO2 down, normal bicarb, you have a respiratory alkalosis. There's no compensation there. You have a normal bicarb.
You're gonna go into the compensation.
You can go into full compensation. You can go into partial or you can go into full. This person here is fully compensated. Right? So your COPDers walk around, they're fully compensated. As long as their kidneys are functioning. You know, you have a COPD that's got a CKD4 or end stage chronic kidney disease on dialysis, they're gonna have an issue because they retain. But if you're a normal COPD, yeah, you'll walk around with a normal pH and just whacked out CO2 and bicarb. So this is part of that relationship I was telling you about, where you could kind of figure out this math, but I'm telling you, it will mess you up if you look at it. Trust me. And that's it. That's blood gas. You just learned blood gases. That's all of it. Go ahead.
If the pH is normal, but the bicarb is high or the CO2 was high, you still consider them like oxygen species?
So you have to remember that this is that it's very, very static in which we look at these things. So if you have somebody that comes in DKA, you may be checking this level every 15 minutes. It all depends on when you check them. So if all of a sudden you're retaining CO2, maybe you have a COPD that comes in and they're having an exacerbation of their COPD. And their CO2 is climbing, but their pH is still normal. You recheck it again an hour later, and now their CO2 is in the toilet. It just depends on when you check it.
CO, consider them in acidosis or not? Like normal.
You only have to consider them in acidosis if they're not fully compensated. And some people will run a little acidotic. So if they run their pH 7.3, it's not a big deal, but they can't run at 7.1. So pH 7.30, high, low, and normal. Low. CO2 60, high, low, and normal. And the bicarb 26, high, low, and normal. Normal. So the pH you said was what? So we're dealing with a acidosis. Which of these CO2 or the bicarb is abnormal? Has to be a respiratory acidosis. Make sense? Make sense now?
Mhm.
So that's a pure respiratory acidosis. There's no compensation there. Nothing. pH 7.50, high, low, and normal. So it's a alkalosis, right? The CO2, 30 and 22. Which one is abnormal? So it's a respiratory alkalosis. Anybody not see it? pH 7.30. Acidosis. CO2 40, bicarb 15. So the bicarb is abnormal. So you have a metabolic acidosis. pH 7.50. High, so it's an alkalosis. CO2 is 40, bicarb is 30. Which one is abnormal? So it's a metabolic alkalosis. Simple? Okay. So metabolically, the respiratory system will always compensate or try to compensate for the metabolic system. So if your kidneys go out of whack, you're going to try to help it out with the respiratory system. Metabolically, if you go out of whack, you're going to try to help it out with the respiratory system. And respiratory wise, you can't really compensate that much on an acute setting in the metabolic process, in an acute respiratory process. I'm sorry. So think about an asthmatic. Asthma comes on quick, right? They lock right up. Are their kidneys gonna be able to adjust quick enough? No. So that in acute respiratory syndromes, their kidneys are not gonna be able to metabolically compensate for them. All right, they're just not going to be able to. But in chronic diseases, COPD, emphysema, cystic fibrosis, interstitial lung disease, pulmonary fibrosis, they can compensate metabolic. But in your acute phase, you can't. Somebody stabs you in the chest with a knife and you drop a lung, right? And you become severely metabolically, respiratory alkalotic. Can you metabolically change that? You're not going to be able to. You're not going to be able to change that metabolic. But metabolically, if you end up with, let's say you end up with sepsis. Let's say you end up with sepsis, gram-negative sepsis from pyelonephritis, which is a kidney infection. Can you help change that respiratory-wise? Yeah, these patients come in, they're breathing 35 times a minute, right? They're trying to blow that off. Or diabetic ketoacidosis. Can you help try to compensate for that? Metabolically, they shut down. The lungs will help compensate quickly. Metabolic system cannot. So this is exactly what we were talking about. So this is talking about an acidosis. I don't know why the question marks are up there. That's weird. We're talking about an acidosis right now. Again, looking at the pH, we see acidosis. If the CO2 is elevated, it's a respiratory issue. Has to be. They're always opposite. So acidosis, the pH is low. If the CO2 is low, it can't be a respiratory issue, can it? They always have to be opposite. So right then and there, you know it's a metabolic problem. That makes sense? That's compensation. So now you can find out exactly what you're looking at. So if we're talking about a patient that has an acidosis, and if the CO2 is elevated, it's got to be respiratory. If the CO2 is normal or even low, it's metabolic. They always have to be opposite. You can't have a CO2 and a pH that are high together. If the CO2 and the pH match, it's a metabolic problem. I'm sorry. If the did I say CO2 and pH? If the CO2 and the pH match, and either way, it's a metabolic issue. They always have to be opposite. Everybody get that? And if the CO2 and the bicarb are heading in the same direction, either up and down, there has to be compensation there. So if I tell you that the pH is low, and the CO2 is low, is it a respiratory or metabolic problem? Has to be a metabolic, right? So if I tell you that the pH is low, the CO2 is low, and the bicarb is low, what is it? It's metabolic acidosis with respiratory compensation. Does that make sense?
Yes.
So if I tell you that the patient has a pH that's high, and their CO2 is high, and their bicarb is high, all three are together. pH and CO2 are both elevated. Can it be a respiratory problem? pH, bicarb are elevated, metabolic, but the CO2 is high. What is it doing? It's a metabolic alkalosis with respiratory compensation. Does that make sense? Who's lost? You can tell me if you're lost. I'll only make fun of you a little. So when my attending taught me this, I was like, I got it. And then he gave out questions, examples, and I'm like, yeah, I don't got it. So if you don't have it, it's fine. Just let me know. With alkalosis is exactly what we spoke about, okay? Look at the pH, it's gonna be high. Where's the CO2 in the bicarb? So with the alkalosis, if the pH is high and the CO2 is high and the bicarb is high, it can't be a respiratory issue. It's gotta be a metabolic alkalosis with respiratory compensation. The only thing that we have to determine now is, we've determined that it's a metabolic alkalosis with respiratory compensation. We did that, that part, that's the hard part. Is it a full or partial compensation? Full compensation means they got in between 7.35 and 7.45. Partial means they didn't fully get to that window that we need to be in. That's all it means. Any questions with this? Go ahead. I'm gonna ask. I'll give you the basics. I'll give it. So look out for that. I'll give you the base excess. I'm gonna give you the pH, CO2, the O2, the base excess, the bicarb. I'll give you all of them. It's very simple. I'm gonna give you a blood gas. You're gonna give me the answer. Go ahead. Yeah, because if they're not in the same direction, there's no compensation. It's just purely one side or the other. Anybody else have a question? Go ahead.
Explain how the base access like what is
Say again.
like the base access, how do we do that?
So the base excess is normal in respiratory abnormalities. That was a COPD or you had a respiratory abnormality. But now use a metabolic. So the base excess will be abnormal the far majority of the time, and only metabolic problem, the far majority. So your diabetic patient that comes in ketoacidosis, that base excess is going to be totally out of whack. So you can look at the base excess first. I mean, it's a sign of weakness, but you could do it. It'll tell you if you're dealing with a metabolic or respiratory problem, but just be careful. It works 99 times out of 100, not 100%. That's why you really want to look at the whole thing. So if you have that patient in DKA and they come in, that base excess is going to be drastically abnormal. So you could have a negative base excess, which means you have to take away X amount of hydrogen ions. So if you have a negative base excess, we'll use crazy numbers. Base excess of -30. You got to take away 30 hydrogen ions to get this guy's pH back up to 7.35. That person is severely acidotic. Does that help you? But in a respiratory patient, you get shot in the chest and you have a pneumothorax. Your base excess is probably normal.
What does it mean practically to add and subtract hydrogen ions? Like, how is a person just like, is it how many ions per liter, deciliter? Like,
So that's another mathematical equation. I think actually Phil goes over that.
okay.
So you can learn it. But when I tell you, you don't have to know it.
Oh.
It's like, did you memorize the Krebs cycle?
At some point.
What'd that do for you? That's what I'm trying to say. I'm only trying to be honest with you. Any questions? All right, so this will be how the test is. 27-year-old mentally challenged. I don't know what some of my abbreviations are. 27-year-old mentally challenged square box with insulin-dependent diabetes arrives to the ER from the institution where he lived. On room air, blood gas is pH high, low, and normal. So we're already dealing with an acidosis. CO2, bicarb. Bicarb's pretty low. 22 to 26 is normal, right? So now we have an acidosis with a low CO2 and a low bicarb. The answer's there, right? So don't look at the answer. So where's the pH? It actually shouldn't even say, it shouldn't say partly, it should say poorly. So the pH, is it near 7.35? This is poorly compensated. you're almost fully compensated at 7.3. You're partially compensated at 7.3. You're poorly compensated at 7.15. But how do we know that there's compensation here? So you have an acidosis here. The CO2 and the pH are both low. Doesn't match. You already know you have a metabolic problem. That does not match. Now you have to know if there's compensation. This is low and this is low. So these are together. These have to be compensated. This and this match. You have a metabolic acidosis with poor respiratory compensation. See how easy that is? It's too easy. Everybody makes it out to be such a big deal. It's not.
Could there ever be both?
Yes, you can have a mixed gas.
Are you,
You
gonna
can.
see that?
You'll jump off the third floor, but yes, you can, and you will have mixed gases, and mixed gases do occur, and we correct them on vented patients.
Telling if it's not compensated because one's like kind of more normal.
Yes,
But if they're both like in the opposite directions, how do you tell?
so it comes down to the mathematics of it then you really have to be able to decide mathematically where's the inverse proportion. And you could have mixed gases where you have metabolic acidosis and respiratory acidosis. You have two different things going on. So that is a very, very small percentage of patients. For the far majority, 99 times out of 100, if you do it this way, you won't get it wrong.
What can give it to me?
Every time. I'm gonna give you exactly what the lab gives you. I'm not looking to, I'm definitely not looking to torture you. And I'm not looking for you to get it wrong. I'm gonna give you exactly what the lab gives. It's gonna look just like this. This is it. Just give me the answer. It's gonna be multiple choice. You don't have to fill them in. Just circle one of them, the right one.
The BE is like not abnormal. Do you just assume it's a respiratory problem?
So you can, and that's what I was trying to say. So one, I think it was her. You can look at the BE, and if it's normal, you can assume it's respiratory, but again, it's not 100%. If you look at it, always look at it. You want to know what you're doing. So if the pH is normal, you can look at the base excess, or you can do the inverse proportionate math from the CO2 to the pH. You don't have to look. You look right at the base excess.
But could you comment if someone PE that's normal, a normal pH and metabolic?
You can, and those are the very, very few and far between. You can.
How do you know they're metabolic?
So you have to do the math. That's
Oh, that's.
the math. So 74-year-old with history of chronic renal failure, chronic diuretic therapy, was admitted to ICU, comatose, severely dehydrated, on 40% oxygen, and blood gas is pH. So alkalosis, CO2, iron high, does not mix. Doesn't mix. So we have to have a what? Base, the bicarb. So what are we dealing with? Almost compensated. So partially compensated metabolic acidosis. Is this person oxygenating well?
Yeah.
80 to 100? Are we good? We're good. No, 40%, but we're good. 17-year-old, 48-kilo male with known insulin dependent diabetes came to the emergency room with small breathing and regular pulse. Room air blood gas is. How's the O2? Good. It's 100%. How's their pH? Severely acidotic. CO2? Severely low. Bicarb? Really low. So and look at the base excess. Really low. So this is a poor attempt of compensation from the respiratory system. It's a metabolic acidosis with poor respiratory compensation. Everybody got it? Without looking at the answer. 67-year-old who had closed reduction in the leg without incident, 4 days later experienced sudden onset of severe chest pain, shortness of breath. Room air blood gas is. Sorry. Oxygen is low.
Yeah.
Do we fix it or no? Always fix the oxygen. Always fix the oxygen first. So the hypoxic. pH. CO2. Bicarb.
B comes as negative, so you gotta take away.
Right.
You know,
So you have a fully compensated metabolic acidosis. Does everybody see it? That's where the BE, that's where you can use your BE. You get it? You good? Everybody, you good? You're gonna get the beats. There is respiratory ones. I gave you all of these. All right, and there's answers to them also. All right, so you can practice this. If you get you're gonna get these. Some of these are gonna stump you and you have to look at the base excess. Others, you're gonna be able to do no problem. All right, but this is how the test is. So the only way to do blood gases is to do blood gases. That it's the only way to do it. So, and really all this is regurgitating everything back. I could tell you if you're metabolic, if you're respiratory, if you combine gets a little tougher and we can correct a lot of those with vents. But right over the phone, I could tell you exactly what's going on. You're gonna be able to do the same thing. You know it now. You're gonna be doing this the night before the exam, and half of you are gonna start crying. Don't cry. It's okay. You're going to get it. Relax. Think about what we spoke about, listen to it, and you're gonna get it again, and you're never gonna forget it. All right. These are your questions to help you study. This is the test. It should look just like this. That's it.
10 questions in brief.
That's it. Tell me what it is. That's it. Tell me what it is. It's not the actual numbers, but
Same concept.
it's same exact concept.
Yeah.
Any questions? All the base sexes are there for you. All right.
Thank you.
Any questions?
So what is Phil gonna teach us? Like this?
So what Phil will do is, what was that? He's gonna teach you the equations.
Okay.
He's gonna teach you the equations and I get nuts with that because it takes everything that we did and it brings you, and it's totally gonna confuse you. Yep, yeah, I can. I could, literally now I could talk to you about blood gases in 5 minutes. You'd be like, oh yeah,